Thanks so much. Jerry, that was wonderful. And I think we have a lot to talk about. And the ending part reminds me of a conference of a few weeks ago where I said something and I was found to be jumping on someone else's quote. I said at the end, with great power comes great responsibility. And somebody said, yeah, I rented Spider-Man last week, and they said that. I think with genomics and this kind of next-gen sequencing power, you've really got a lot of responsibility, and we all have a lot of responsibility. And I think that the shared collaborative view is probably going to be the right one. And I want to start off by asking you, Jerry, the premise is that the targeted gene analysis is very efficient. Where do you see the gaps in that? I mean, we heard about the BRAF mutation in melanoma. Can you just give just a quick synopsis of what do you think of that statement? True, sometimes true, mostly true?
Well, I think one of the things that we see as a misunderstanding, in the press, you see the costs of sequencing are coming down. And if you look at the NHGRI data recently, they've actually flattened, and I don't know about other folks in the room that might be using a platform. We've been asked for significant increases in payment to the platform companies. So we don't see that happening the way it's being portrayed. Over time, yes, I think it will be more efficient. Where the rubber meets the road is the enormous effort that's required to make sense of the data that's coming off the sequencers. And that, in addition to the upfront process of actually working with the DNA to make it, shape it up, if you will, to get it into the sequencer, these are enormous costs associated with that. And while you can run it, you can run the test and get the data off the sequencer very efficiently, we still have an enormous amount of investment in, building out the knowledge base to make sense out of all of the different combinations. It's a multivariate problem, really, to make sense of the big data.
So I guess as the hugeness of the data increases, the ability to have complete clinical utility goes down. So huge amounts of data, well, not really, but the ability to make sense of it. So I'm going to start with Lee and then John and Mike. So based on what Jerry just said, what do you think about the premise of the fact that he's not just doing really high-tech analytic work, he's now in the bioinformatics space, and he's trying to make sense of this huge amounts of data? Where would you take that as a payer?
Well, Jerry, I had mixed reactions about what you said today. I was doing fine until you showed the single case. So I'm going to take a long-winded approach to your answer. What percentage of your patients with breast cancer ERBB2 are responding?
I can't answer that.
You can't, because you have one case.
Right.
And it's that case. Well, you were presenting that. I got a request to treat someone with a HER2 ERBB in a cancer that was not previously expressed, metastatic to the brain. They want to use combination TKI and Herceptin. And they're doing it because of the kinds of promotions that you just gave there. You were very responsible until that anecdote hits. And when you tell those kinds of stories, the world thinks that we are now state of the art. And the fact of the matter is that we still have not a single study that shows us that the concept of using an actionable gene in a cancer for which there is no evidence is a proven strategy. We do not know if that's going to produce responses 100% of the time, 50, or once. And we just don't know. So the need for clinical data and evidence is absolutely essential, and that's what we want from your database. Right. But in the meantime, you can't expect the public to fund that data because the resources are too scarce. Right. So people are looking to payers to say, well, go ahead and pay it. It's an actionable gene. And I think you got to walk a very cautious line about not over-promoting that concept.
Mm-hmm. Yeah. So, yeah, I would say that we're not suggesting that you take one case study and that becomes policy. What we're suggesting is we need to collaborate to figure out and how to aggregate those ends of one to come up with a statistically reliable and validated approach to say that there's clinical utility in those types of mutations in those patients because we now have 50, 100, whatever the number is, I wasn't, trying to say that, using a case study like that was, therefore, everybody should be covered. There's a
know
lot of
you-
work to be done.
I know you weren't, because I know you personally,
Right.
but that is the impression that's coming off both to the public,
Right.
those patients out there, and also to too many providers.
I think there's really an oversimplification of this whole field, and I'll just give one example. So we know that if patients have BRAF V600E mutation and melanoma, they'll respond to several drugs that target that mutation. But we also know that if you have that same mutation in colorectal cancer, that you don't get a response. Right. And so not only do we not know for a specific gene mutation, what the response is in different tumors. We also don't know what combinations of mutations may impact the likelihood of response to a specific therapy or non-response. So at the same time, when we have more and more information about what the mutations are, we have less and less information about whether or not patients are likely to respond. And the real challenge is what evidence do we need to inform the decision for payers, let alone patients and physicians, about when to pull the trigger given a specific mutation. I don't know the answer to that, but Mike.
But let me just interject.
I have the answer. I'm glad you all came today.
Let me interject
So I'm
just
gonna-
1 second, Mike.
Yes, go ahead.
The master lung protocol that you are participating in is a beautiful example of how to do that. Sorry.
So let me take that one step further, right? So bioinformatics is a little bit of an exaggeration because really what it is cataloging. And so Jerry said that, there's a lot of mutations and that's because cancer screwed up. So how do you decide which of those mutations to act on? And the answer is, well, I think it's a good idea, right? So either it is a driver in another cancer where we have an effective therapy. We do something because we can do something. Or more typically, you've got a bunch of guys sitting around a table who think they're smart and they decide which one goes first. So here's the problem. This is such an exciting technology and it's so sexy. And we are not equipped to obtain the answers to these questions given our current payment model or given our current research model. And so even the master lung protocol leaves much to be desired. And so I had mentioned before that I think that there's a tremendous leadership vacuum in vetting the analytical validity of the test producers. There is an equally humongous vacuum in the clinical research world in developing new paradigms for assessing how smart those guys are who are sitting around that table. And I'm not going to say that I think Jerry's company should do it, and I'll tell you, I'm quite confident that Aetna's not going to do it. You can probably tell me if you think I'm wrong. And for some reason, there's a belief that the insurer should pay for this research, and I'm not sure where that came from. But the truth of the matter is, a 300-person randomized clinical trial is not going to be the way these studies are done. There's got to be another approach. And I don't know if there's anybody from FDA in the room, but this is something that I think has got to be dealt with, and it needs to be dealt with soon because it is so sexy. It's going to start getting done, and then we're not going to know what to do with it.
So I think a good follow-on to that is the issue that was raised earlier about what could be the collaborations between pharma and payer, given that there is a present vacuum and knowing how slowly the wheels grind in the legislative and political world, if we don't see the answer today, it's probably not happening for at least 12 to 18 months.
Yeah.
So we'll go back. So Mike, John, Jerry, and then Lee. Any thoughts on that?
So there are examples from NICE, for example, where bortezomib was not approved, but there was a decision made that if it worked, they would pay for it. So that model does exist. So here's, to me, the challenge with that. What's good enough? How much of a response is good enough? So if we use the case example, the patient had 3 further lines of HER2-based therapy over the course of 3 months. So I would say that via almost every clinical trial design that I know of, a patient who responds to therapy for 1 month is not a responder. That's not a meaningful response. Okay, I get the quality of life issue. But if you're measuring objective response, the objective response lasted a month, that ain't such a great response. And so let's be honest, it can't just be about one mutation. If it were, as Dr. Ramsey said, every single BRAF patient should respond. That is not the answer. It cannot be. It is inconsistent with what we know today. So what is the answer? How do we decide? So we talked about depth of sequencing. Okay. So if 2% of the cancer cells have the mutation, is that as good as if 22% or 82%? So these guys, they're going deep. They want to find every single one. Is that the right answer or the wrong answer? I honestly don't know. I'd like to know the answer to that question because it might make us move the research ball a little further along.
And if it's really cataloging and it's a huge task, John, Mike and Lee, at least in the imaginary world, have huge resources. We know that's not true. But you have even less. So how do, private plans or blues plans, how do you guys cope?
Well, I think the reality is today, I think, that under the Accountable Care Act, we're required to pay for phase 1, 2, 3, even 4 cancer clinical trials and other clinical trials where patients have a life-threatening illness. So I think there might be an opportunity in well-designed clinical trials for payers to fund this. I think the general sense is that in clinical trials, care is more cost-effective because it's more standardized. So I don't a priori have any problems as a payer funding a well-designed clinical trial, but what I don't want to fund is an N-of-1 trial. Because there's no good evidence about A, what the results mean, and B, how the provider is going to use that information in making decisions. One of my favorite oncology friends has said, well, that test has got to be better than my brain, and that may be the case, but we don't know if that will produce better results.
Lee, did they say it all, or is there more?
Well, I think if I were king for a day, what I'd love to see is the master U.S. protocol on this concept, that people would get their sequencing test done, and if they have an actionable gene in an unproven cancer, I'm not talking about HER2s and breast cancer or name your already established biomarker. What I'm talking about is exactly the scenarios that Jerry presented. We've got an actionable gene in a cancer that's never been tested. I'd like a master protocol where the FDA says to the pharma, you can provide that drug as part of a trial, which they can't do today. And we, the payers, would pay for the routine clinical costs of that trial. By the way, the experimental therapy is not covered under ACA, just to clarify that. But we provide the routine care, and the data is gathered, and if we find suddenly that we have a series of 30 patients and 68% of them are responding, then I'd be off to the FDA for my next approval. We know that's possible. There are organizations that have put that together. I point to iSpy. It's not easy work, but it could be done.
Jerry, can your organization withstand the weight of that kind of request? Can anybody in this space?
Well, I mean, I've talked about the collaborative approach, and I think that the physicians that are here at the table are leading physicians in terms of the payer perspective, in terms of how do you figure out a multivariate set of questions, right? Alone, no. It's not sustainable for us to take it on alone, but in a collaboration, in a federated model where we're working together across multiple systems, multiple contributors to the data. The lung master protocol is one way to do it. There might be other ways to do it, but I think getting together and thinking out of the box and trying to figure it out will have an enormous benefit for patients over the long term.
And we all know that the goal is to, identify which therapy targets the right marker, the right patient, and then we get back to the traditional right patient, right treatment, right time, right drug.
Right.
Did you want to say something?
Well, I struggle still because I was happily riding this train for at least a year or more until Gerlich published the paper, I think it was in 2012, looking at tumor heterogeneity. And the oncologist in the room probably knew that, but as a pediatrician at a health plan, I had no idea what that meant until I read the paper. And now we've got not potential for sampling bias or sampling error. We also have discordance between the original tumor and any metastases. So I'm still struggling to figure out, even if I had information, could that necessarily produce a better outcome if I don't know the discordance rates or the presence of heterogeneity?
Yeah, so your
So how do you
confidence
deal with
is,
that?
yeah, you're not as confident as you could be, even if the science was right, because you could be hitting the wrong part of the
Yeah.
tumor.
And with escape mechanisms that are present, it's no surprise that I might get a 1 month or I might get a variable response and a short response.
Yeah, I think the real question is, are we looking at the right type of patient, right? So, cancer's unstable, changes over time. Looking at end-stage patients, not sure that's the right place to look. I mean, I think, so the real fear is we're going to exhaust every single conventional option and then we're going to throw whatever the test shows at the patient. So we have increased cost of care. We have not necessarily improved quality of care. We've made ourselves feel good that we've done, quote, everything, end quote, which may not be actually the best thing. Should this guide therapy out of the gate? To me, that's the real question. And if we've decided this should guide therapy out of the gate, then we should make a decision about whether or not we think the things that we used to do are still of value or not, if we're having therapy guided out of the gate by this approach. And I don't have the answer to that, but I think that is the heart of the question.
Yeah, I would agree. If I could have an ideal trial, it would be the first relapse, randomized to either genomically directed or standard of care. And let's see whether the concept brings forth some kind of extra value.
Yeah.
It is harder at the end of the trial, no question about that.
Yeah, I want to ask Jerry and then John. Jerry, when you get the samples, do you get historic information that tells you how many courses of therapy, what round the patient's on before they come to you?
Yes and no. So it oftentimes we have to reach out back to the practicing clinician to uncover that information. It's an advantage if you're an academic medical center because you can access the medical record. You're part of the care team generally. You can go downstairs and maybe even see the patient in concert with the oncologist. So we don't have that opportunity in our world. So we have to reach out and follow up to get more information on the clinical situation of the patient.
Yeah, John, I'm sorry.
Speaking about nth-line therapy, I think there's a real appeal here if we could prove what optimal first-line therapy is and optimal second-line therapy is, because I think today people are willing to undergo third and fourth and fifth-line therapies because they're still healthy, and the drug that I used the first time, the second time was just a guess at what might work. But if we had targeted therapy, first and second line, would that reduce the need or the appeal of third or fourth or fifth line therapies because we used what we knew was best the first time and second best in second line? Lee, what do you think? Would that?
No, I think it makes perfect sense.
So I think you're exemplifying that saying about there's things we know, there's things we don't know, and there's things we don't know we don't know.
There is going to come a point pretty quickly, I think, where the tension between these two is going to hit the public and explode. Clearly, there is a groundswell of physician community who wants to go out and do this on every case and start directing therapy that way without the evidence. I know that each and every one of you sees that request on a probably hourly basis now. So we're here. It's already, people are already taking off with this without having the evidence solidly developed. And the question is, will we be forced to come off our position where we're saying, no, you got to have the evidence before we're beginning. And when the evidence is there, we'll be there.
And it's important to note that Jerry and his company is actually not really the problem. The thing is that many academic medical centers have developed their own laboratory-developed tests.
Absolutely.
They're actually less exhaustive than Jerry's test. There are both academic as well as community-based centers that are advertising directly to consumers that they are in fact providing higher quality care because they are doing this. They are personalizing therapy. And so listen, we have to, as a group, condemn that activity. It is detrimental both to the development of knowledge as well as to the best possible outcomes for our patients, because they may well be foregoing therapy that would have some activity because it's a patient-centered oncology care. Foregoing traditional therapy that imperfect but has measurable and predictable activity in lieu of this kind of approach. That just sounds good. And I have a real problem with that.
Would you have a problem if this were part of a clinical trial?
No.
Okay.
And I think that's great because we're actually trying to answer the question.
Yeah.
Well, last closing remarks. We had Mike, we had John, Jerry, then Lee. Anything last to say?
I just wanted to go back to this morning and point out how several speakers this morning said in the case that you gave, hospice and palliative care were about 2 years too late. So once again, let's come back to that. That lady knew the day she was diagnosed that she was in trouble. And where was the palliative care doc to help her with that decision-making process?
Yeah, that's a system problem. Jerry, anything last to say?
Yeah, I mean, personally, having endured 2 close family members going through that process and being lost in the process and having, cytotoxic therapy two weeks or a week prior to ultimately passing, I would agree that that's a big rallying point. At the end of the day, we're hopeful that our approach will enable, targeted treatment to eventually, with evidence, come earlier in the cycle of diagnosis and treatment, and then it will make a huge difference in patient outcome and quality of life.
Great. Thanks so much, Jerry. Thanks for our panelists. This was a great topic. Thanks again.